Alright, now I have a question to start off the topic of clonomimetics. Now, what effect do clonomimetic agents have on cholinergic outflow? Clonomimetic agents all are going to act to increase the cholinergic outflow. So the name clonomimetic actually mimics the action of acetylcholine, which is going to act to stimulate the cholinergic receptors. So here's another question. What do meiosis, diarrhea, urination, bronchospasm, and lacrimation all have in common? Now, all of these are going to be signs of increased parasympathetic nervous system activity. Sweating is usually a sympathetic response, but unlike most sympathetic responses, it's going to be mediated by acetylcholine, so it can be also caused by clonomimetic agents. So an easy way to think of all of this in this class of drugs is that they're going to make people ooze from every orifice. That is, they increase secretions and cause a wet picture, turning everything blue. So I'll turn the slide blue because when you think of clonomimetic agents, I want you to think of a wet picture. So with this in mind, it'll be easier to remember that they can exacerbate certain conditions like COPD, asthma, or ulcers by increasing secretions of respiratory mucus or gastric acid. So there are going to be two major categories or classes of clonomimetic agents. You have the direct agonists and the indirect agonists. So how do direct clonomimetic agents work? We're going to be talking about the direct class of clonomimetic agents. So this will include bothanicol, carbachol, pilocarpine, and methacholine. So these are all going to be your direct agonists. In other words, they're going to directly stimulate the muscarinic receptors. So we're going to start off with bothanicol. So bothanicol is going to be used for post-operative and neurogenic ileus and also urinary retention. So a useful mnemonic is Bethany, call me maybe if you want to activate your bowels and bladder. Carbachol is primarily used for glaucoma, and it works by stimulating the pupillary contraction and the release of intraocular pressure. So you can remember this drug as a carbon copy of acetylcholine. Pilocarpine is going to be a potent stimulator of sweat, tears, and saliva. It's going to be resistant to the acetylcholine esterase, which is going to break it down, so pilocarpine is going to have a longer half-life. A helpful mnemonic to remember is this. You cry, drool, and sweat on your pilo, or pillow. So, pilocarpine. That's an easy way to remember that. And then lastly, we've got methacholine. Methacholine is used as a diagnostic test for asthma. When it is stimulated, it's going to stimulate muscarinic receptors in the airway. When it is inhaled, and patients with asthma will be hypersensitive to it, leading to an exacerbation of their condition. I don't really have a good way to remember this, but it is still important. Don't forget that asthma can be diagnosed by a methacholine challenge test. The indirect agonists are our second class of clonomimetic agents. Now, these will work by not directly stimulating the muscarinic receptors. If they don't directly stimulate these receptors, so then how do they work? Well, they act as clonomimetic agents by inhibiting acetylcholinesterase, which is going to be that enzyme that is responsible for breaking down the acetylcholine in the synaptic cleft. So if you inhibit that enzyme, acetylcholine is going to be present and last longer. Therefore, the indirect clonomimetic agents increase endogenous acetylcholine levels. Now, we've got a whole bunch of agents to talk about here. We'll start off with neostigmine. Neostigmine is an indirect acetylcholine agonist, and this is useful and primarily used for post-operative and neurogenic ileus, and also urinary retention, long-term treatment of myasthenia gravis, and the reversal of post-operative neuromuscular junction blockade. Now, it is a quaternary amine, which means that it is permanently charged, and it's not going to penetrate the central nervous system. Now, to remember this, just think about how neo kind of sounds like no, so neostigmine is no CNS involvement. Pyridostigmine is used for the long-term treatment of myasthenia gravis. Now, it's also a quaternary amine, so therefore it's not going to penetrate the CNS. Edrophonium is an extremely short-acting acetylcholinesterase inhibitor, and it's going to be used primarily for the diagnosis of myasthenia gravis. Physostigmine is used in the case of atropine overdose. An easy way to think of this is that physostigmine fixes atropine toxicity. So physo fixes atropine toxicity. Lastly, donezepil is used to treat Alzheimer's disease, and it's been shown to improve cognition and behavior. Now, this drug is believed to be helpful in Alzheimer's disease because it combats the reduction of acetylcholine levels caused by the death of cholinergic neurons in the brain. So remember that Alzheimer's disease is caused by decreased acetylcholine levels. It's also important to note that donezepil only transiently improves symptoms, and it's not going to be an actual cure itself after the disease has developed. It may alter the course of disease progression, however. So with all cholinomimetic agents, be careful for the exacerbation of COPD, asthma, and peptic ulcers when giving these to susceptible patients. Now, why is this? It is because these drugs cause bronchoconstriction and increased gastric acid release. So make sure that comorbidities are not going to be worsened when you give these agents. Alright, let's try out a flash quiz. Time to test your knowledge. Suppose a patient presents with complaints of getting out of chairs and problems climbing stairs. Also, her husband has noticed that her left eyelid has been drooping the past couple of weeks after she comes home from work. When she presents to your office, you notice her right eyelid is drooping as well. You inject edrophonium and the drooping improves. What is your diagnosis? I'll give you a second to think about this. This patient presented with muscle weakness and ptosis, both of which are classic symptoms of myasthenia gravis. These symptoms typically present later on in the day, and improvement of symptoms with edrophonium is going to be diagnostic for the condition. Now, why do her symptoms improve with edrophonium? Remember, we just covered this agent. Now, to answer this, you need to remember the etiology of the disease of myasthenia gravis. Now, we've got a quick little sketch here that I can do. Here's a presynaptic neuron. Here's a postsynaptic neuron. Now, we've got acetylcholine receptors on our muscle here. So this is our muscle fiber. And we've got these acetylcholine receptors. Now, myasthenia gravis is characterized by circulating antibodies. Now, an antibody is just going to be one of those things that you learn from immunology all around the body. So you've got these circulating antibodies. And what these are going to do is they're going to block the acetylcholine receptors at the postsynaptic neuromuscular junction. So these are going to come in and block these acetylcholine receptors on the muscle, and these will eventually induce receptor downregulation over time. Now, by increasing the availability of acetylcholine within the synaptic space with edrophonium, we can actually enhance the ability of the endogenous acetylcholine to outcompete with these circulating antibodies for binding with the acetylcholine receptors, and thus allow her muscles to function better temporarily. So, if the symptoms improve with edrophonium, she most likely has the diagnosis of myasthenia gravis. Alright, as you can see here in the picture, myasthenia gravis can present with droopy eyelids. Now, this is because there are few spare nicotinic acetylcholine receptors in the eyelid muscles than elsewhere in the body. So a reduction in the number of nicotinic acetylcholine receptors in myasthenia gravis, like we talked about, will initially manifest clinically as a droopy eyelid. So there's not as many nicotinic acetylcholine receptors. Alright, now let's move on to the cholinesterase inhibitor poisoning. Notice again how the slide is blue. Remember, we already discussed the breakdown of acetylcholine, which acetylcholine gets released into the synaptic cleft where it can act on a receptor, but it can also be broken down by the enzyme acetylcholinesterase. So, cholinesterase inhibitor poisoning occurs when a person ingests or absorbs too much acetylcholinesterase inhibitor. Now, what symptoms will we see? We've got quite a big list here. Now remember, oozing from every orifice, or the wet picture. So that's going to be diarrhea and abdominal cramping, urination, meiosis, bronchospasm, bradycardia, excitation of skeletal muscle, and the CNS. We've got lacrimation, we've got sweating, salivation. Now, all of these symptoms can be remembered by using the mnemonic dumbbells, where you can see here the first letter of each word has been turned to red to give us our dumbbells. Now, remember from earlier that sweating is going to be unique in that it occurs only via acetylcholine-mediated sympathetic activity. While the rest of these are going to be typically associated with your parasympathetic activity. Now, cholinesterase inhibitor poisoning typically is due to organophosphates, such as parathion or malathion, which are going to be irreversible acetylcholinesterase inhibitors. Because organophosphates have been used as ingredients in insecticides, the USMLE has often asked this question in the context of farmers. So, for example, you may see the following question. A patient comes to your office with complaints of excess sweating, urination, bradycardia, lacrimation, and difficulty breathing. He states yesterday that he sprayed his field for insects. Which enzyme is most likely inhibited by the insecticide and is causing this patient's problems? So I'll give you a few seconds to think it over. So if you thought acetylcholinesterase, you would be right. Acetylcholine normally gets released from the nerve terminal. It's going to mediate its effect on the receptors on the postsynaptic neuron and eventually gets degraded by acetylcholinesterase. Remember, ACHE. Now, in the question above that we just talked about, the USMLE loves to test your understanding of this subject and how it may present clinically. Farmers may use organophosphates, which can act to inhibit the enzyme acetylcholinesterase. Now, this is going to prevent the degradation of the neurotransmitter acetylcholine in the synaptic cleft, which is going to increase the amount of acetylcholine present in that cleft. This is going to lead to that dumbbells picture or the wet picture of sweating, urination, bradycardia, lacrimation, and difficulty breathing. Alright, so how are you going to treat this farmer that comes in with acetylcholinesterase inhibitor poisoning? To treat this patient, you should administer atropine, which is a muscarinic antagonist, and pralidoxime, which is a chemical antagonist used to regenerate active acetylcholinesterase. So here is a little cartoon example that we can use to demonstrate this. Let's take some pralidoxime here, and that pralidoxime is going to be taking the inactive form of acetylcholinesterase here and regenerate it into an active form, which is then going to go on to degrade acetylcholine into its products, which is going to be choline and acetate. Alright, so the caveat with pralidoxime is that it must be used within hours after poisoning occurs. So if too much time passes, the inactive form of this acetylcholinesterase will be permanent by a process termed aging, and then thus pralidoxime will no longer be able to reverse the inhibition. So there's two things you need to do, atropine and pralidoxime.